Good day to all of you. I am Dr. Jamuna Shaktish, your faculty mentor, Pathology from Dopamine. So today we'll be discussing the INICET Recall 2025 questions. Overall, there were 17 questions in pathology and most of them were very straightforward and simple. So we'll look at the questions one by one. So this was the first question. Which of the following stains is not used for detecting fungus? Yes. So we are all aware the stain used for detecting fungus is GMS, Gomari, methanamine silver. So this is the stain which is commonly used. This is the most commonly used stain. We have other choices like Congo red. So Congo red is basically used to detect amyloid. We are all very much aware. We have Mason's fontana, which is used to detect melanin. And we have PAS, which is basically a stain for carbohydrate. So here, which is not used for detecting fungus. So most of the time what happens, even a PAS can detect fungus. So that is also there. That is also the stain. So GMS, PAS. What about this Mason's fontana? Mason's fontana is basically used to detect melanin, but the fungus on the skin, we call that as demataceous fungi. So all those fungi will stain positive for Mason's fontana. So the stain which is absolutely not used for detecting fungus is Congo red. The only indication of Congo red is detecting amyloid, apple green birefringence in a polarized microscopy. So here the right response is Congo red. So the next question. In which of the following immunodeficiency disorders is HLA mismatch, transplant rejection least likely because of the absence or severely impaired immune response? So all the four given are all immunodeficiency disorders. They are basically primary immunodeficiency disorders. So we will see one by one. We have Shiryak-Higashi, Wiskott-Aldrich, Bahr lymphocyte syndrome, and Job syndrome. So what is this Job syndrome? So that is IgE. Hyper IgE is Job syndrome. So the persons will have immunodeficiency. So that is Job syndrome. So what is this Bahr lymphocyte syndrome? So in Bahr lymphocyte syndrome, there are two types, type 1 and type 2. In type 1, what happens is HLA1 deficiency will be there. So the MHC, major histocompatibility complex 1, will not be there. So what happens? MHC, major histocompatibility complex 1, will bind with CD8 T lymphocytes. So since this HLA MHC1 is deficient, obviously HLA mismatch transplant rejection cannot occur, isn't it? So the right response here is Bahr lymphocyte syndrome. So what is this type 2, which is actually HLA2 deficiency? That is a class 2 MHC2 genes are not available. So this 2 will combine with CD4 lymphocytes. So these are the two types of Bahr lymphocyte syndrome, type 1 and type 2. So in these people, obviously, transplant rejection cannot occur because of the absence of MHC 1 and 2 complexes. So we'll also have a quick recap of other two, that is the Shiryak-Higashi and the Wiskott-Aldrich syndrome, because they are again very, very important. So coming to the Shiryak-Higashi syndrome, so we know there is a mutation in LYST gene, LYST gene. So here the problem is defect in lysosomal trafficking. So what happens? There is a defective fusion of, phagolysosome. So these people will have Shiryak-Higashi syndrome. So what are all the clinical features? We will go with the name of Shiryak-Higashi. So C for CNS manifestation. So patient can have ataxia. They can have peripheral neuropathy. So H goes for hemorrhagic tendencies. DI obviously for decreased immunity. So these people have increased chances of bacterial infections. So that is very high in these people. What about this A? A stands for the typical clinical appearance of albinism. So albinism not only in the skin but also in the eyeball, which we call as oculocutaneous albinism. the typical this appearance. So this is silver hair appearance, which is very classic of Shidia-Kikashi syndrome. K, instead of K, you can remember it as C. So C for this coarse granules in neutrophils. So as you can see this picture here, so this is a core cytoplasmic granules. So these are all the clinical features of Shidia-Kikashi syndrome. We'll also look into the other choice, that is the Wiskott-Aldrich syndrome, which is also known as microplatelet syndrome. See, as you can see this picture, this is the normal platelets. So see the size of the normal platelet, which will be around 3 microns, whereas people in Shidia-Kikashi will have tiny platelets, very, very tiny, around only 1 micron. So when we do the complete blood count in the auto-analyzer, what happens? The analyzer sometimes misses these sizes. So the patient clinically in the CBC will have a thrombocytopenia. So how are the platelets going to be? They are all microplatelets. Okay, so in the skin, they can have eczema in the skin. So immunity levels will be low. To be specific, IgM level will be low. So IgG levels will be normal. And paradoxically, what happens? This IgA and IgE and IgA levels will be high. Okay, and what is the gene that is mutant here? That is the VAS gene, which encodes the protein VAS protein. Okay, so that is about Wiskott-Aldrich syndrome, also known as microplatelet syndrome. So the right response for that particular question would be Barr lymphocyte syndrome. We'll see the next question. Very practical question is being asked. Erythropoietin is useful in the treatment of which of the following type of anemia? So we are all aware clinically erythropoietin, we use it in and out in patients on renal dialysis. So people with chronic kidney disease, anemia of chronic disease, any anemia of chronic disease, we use erythropoietin as a therapy. And you're all aware that in anemia of chronic disease, what is the problem? Because of increased inflammation. So because of increased inflammation, what happens? Hepcidin levels are, the inflammatory mediators are going and indirectly affecting the hepcidin levels. So that hepcidin levels will impair iron absorption. So that is the problem in anemia of chronic disease. Also, the inflammation is, so this is one mechanism. So the second mechanism is, so inflammation will destroy the RBC precursors. So in anemia of chronic disease, when we treat these people with erythropoietin, especially people on chronic kidney diseases, okay, so what happens? Because of the damage to the kidney, erythropoietin level synthesis will be very low. So when we treat the people with erythropoietin, they have a good response to anemia. Whereas in nutritional anemia, we have two types. One is iron deficiency, other is B12 and folic acid deficiency. In all these cases, the problem is in B12 and folic acid, the erythroid precursors are not maturing. There is an ineffective and dyserythropoiesis. So obviously, even if you give erythropoietin, it is not going to help because in these people, already erythropoietin levels will be high. Similarly, in iron deficiency anemia, the problem is with the hemoglobin synthesis. So obviously, these people are also not going to respond to erythropoietin. In problem with myelofibrosis and aplastic anemia, the erythroid precursors are destroyed and the entire marrow is replaced by fibrosis. So in such cases also, erythropoietin levels are already high. So these people are also not going to get benefited. So the only right response is anemia of chronic disease, to be specific, chronic kidney disease. So that is the right answer. So we'll move on to the next question. Very simple question. So what is this image? So whenever we see these gaps, so they are all alveoli. And what is this thing that is leading to the alveoli? Obviously, in the lung, you have the trachea, then you have the right and left bronchi, then you have the bronchioles. So these bronchioles will end in pre-terminal bronchioles, then the terminal bronchioles, followed by the respiratory bronchiole, alveolar duct, and alveoli. So we'll see this picture. So what is the arrow pointing here? So they are the respiratory bronchiole. So this is the terminal bronchiole. So these are the respiratory bronchioles and these are the alveolar ducts. And this is the alveoli. So this entire thing, the respiratory bronchiole, alveolar ducts and the alveoli constitute what is called as the acinine, which is the terminal unit. So now let's look at the picture. So what is shown in this picture over here? So it is nothing but the respiratory bronchiole. So this is the respiratory bronchiole. These are all the alveolar ducts and the tiny sacs are the alveoli, which I have already marked. So what is the structure shown here? That is the respiratory bronchiole. So we'll move on to the next question. Very practical question. Serotypes causing cervical cancer. Very simple. It is 16 and 18. So here, look at here, 31 and 33 will also cause, but 70% of the cases will be because of HPV 16 and 18, followed by 31 and 33. So if 16, 18 is not in the choice, probably we will choose 31, 33. So 6 and 11 will cause benign warts. Okay, so the right response here is 16, 18, a straightforward question. So the next one. So we have a 24 years old woman. See the age, it is a young age, presenting with a lump breast. Biopsy revealed DCIS, ductal carcinoma in situ with comedonecrosis. See, in DCIS, there are 3 types. So this type 3 is comedocarcinoma, comedo-DCIS. Okay, and her mother died of breast cancer at the age of 31. So there is a family history. Due to financial constraints, only one genetic mutation test can be performed. So which of the following genes should be tested first, considering the clinical and the family history? Okay, so whenever we deal with familial breast cancers, we know there are 2 mutations. One is a BRCA, BRCA1, other is a BRCA2. So here in the choices, only BRCA1 is given. So that should be the right response. You know that P10 mutation will cause Cowden syndrome, remember? So DEN, I told you, no, P10, we have discussed this so many times. So 10 and DEN, Cowden syndrome, especially thyroid cancers. Imagine the bell of the cow, we will look into that. Similarly, P53 will cause Lee-Fromeny syndrome. And yeah, P53 mutation can also cause breast cancer. But remember, this lady is not having a breast cancer. She is having the precursor, DCIS only. Later stages, she will also have P53 mutation. But here, she is only having carcinoma in situ. So if at all she has to undergo only one gene, then probably we will choose BRCA, BRCA1. So as discussed, BRCA1 and BRCA2 in familial breast cancer, it also causes, remember, endometrial cancers. That is also possible. P10 Cowden syndrome, I hope all of you are very familiar with this picture. The bell of the cow is thyroid, skin and mucous membrane lesions, colorectal cancers, breast cancers, breast cancer, endometrial cancer. Lee-Fromeny syndrome, P53 mutation will cause. These people will not have only carcinoma, but remember, they will have sarcomas as well. Sarcoma plus carcinoma. Any cancer, any sarcoma, anything can happen with P53 mutation, that is Lee-Fromeny syndrome. And CDH in familial gastric cancer. Remember, CDH mutation in familial gastric cancer. So in this particular case, the right response would be BRCA1. So we'll go to the next question. Which of the following renal histologic features is characteristically seen in diabetic nephropathy, but not in any other glomerulonephritis? When you look at the choices, Kimmel-Steele-Wilson lesion, mesangial sclerosis, glomerular basement membrane thickening, food process effacement. See, food process effacement is typically seen in minimal change disease. The minimal change disease, which is actually the most common cause of nephrotic syndrome in children. Glomerular basement membrane thickening and mesangial sclerosis can occur in diabetes mellitus, but it can also occur in other nephrotic syndromes as well. So the classic lesion, the classic diabetic lesion seen in diabetic nephropathy people is Kimmel-Steele-Wilson lesion. The other terminology is also called as Arman lesion. So we don't use this Arman terminology right now. The current terminology is Kimmel-Steele-Wilson or nodular glomerulosclerosis, but remember this as well, Arman lesion. So how the image will look, see I have given, so this is the normal glomeruli and this is this Kimmel-Steele-Wilson lesion. What happens is, see the round structures here, they are all the capillary loops, and in between the capillary loops, as you can see here, this is the mesangial matrix. So when you look at the mesangial matrix, there will be increased cellularity with nodules like this. So this nodular glomerulosclerosis is also called as Kimmel-Steele-Wilson lesion, which is the classic lesion seen only in diabetic nephropathy involving the glomeruli. So we'll go to the next question. Which of the following statement is false regarding gene and cancer? So something like match the following is given. So we'll see SKT11. SKT11, it is a classic mutation we have seen so many times in Peutz-Jeghers syndrome. So in Peutz-Jeghers syndrome, if we can recollect what is the problem, the person will have multiple brown patches along the oral mucosa, buccal mucosa, and also in the anal verge. They will have a family history, multiple hematomatous polyp all along the GIT. So that is the classic sign in Peutz-Jeghers syndrome. People with Peutz-Jeghers syndrome have a high risk of not only the colonic carcinoma, but also they have a risk of carcinoma breast, gastric cancers, pancreatic cancers. So SKT11 causing breast cancer, yes, it is possible. Similarly, BRCA2, BRCA1 and BRCA2 in male, female will cause breast cancer. The male counterpart, so prostatic cancer, yes, it is also right. TP53, the gene which is mutated in almost all the carcinomas and sarcomas, but not mucosal neuroma. Mucosal neuroma is benign. If you remember, mucosal neuroma is a component of MEN syndrome. If you remember MEN2 syndrome, we get mucosal neuroma. So this is the right response here. And P10, we have discussed in the previous slide as well. That is a Cowden syndrome, where the person in front of the neck, so they will have thyroid lesion. So that is also right. So the false response here is P53 is not associated with mucosal neuroma. So we'll go to the next one. Caspase 1 is involved in which of the following process? Apoptosis, necroptosis, ferroptosis, pyroptosis. So we know that caspases are involved in apoptosis, isn't it? So caspases means apoptosis. So in apoptosis, we know there are two pathways. One is the intrinsic pathway. So intrinsic is actually the mitochondrial pathway. We have the extrinsic pathway. Extrinsic pathway is the death receptor associated pathway. And intrinsic pathway will involve caspase 8, and extrinsic pathway will involve caspase 10. Then you have the common pathway involving caspase 3 and 6. Okay, so this is apoptosis. Necroptosis is actually the other name for necrosis. See, this is called programmed cell death. Necroptosis is combination of necrosis and apoptosis, but why we don't call that as necrosis? Why we don't call that as apoptosis? Because it is caspase independent programmed cell death. So that is necroptosis. So caspases have no role. Coming to ferroptosis, here it is iron involved. Pyroptosis. So pyro means fever. So pyrogens, to be specific, interleukin 1, which is a pyrogen. So this interleukin 1 will activate caspase 1. And this will cause apoptosis. So since caspase 1 is involved, they have kept it as a separate category. So caspase 1 is involved in which process? It is pyroptosis. Okay. What is the most common inherited bleeding disorder? Very simple, straightforward question. Without wasting time, it is von Willebrand's disease is the most common inherited bleeding disorder. Which of the following cancers is not associated with obesity? Again, a very practical question. So obesity, so what do we mean here? The person can have a metabolic syndrome, which we call it as metabolic syndrome or syndrome X. So obese people, you know, endometrium, we used to classify endometrial cancers into two types, type 1 and type 2. So type 1 has a very clear association with obesity. Pancreatic cancer, yes, association is there. Gastric cancer, obviously, lifestyle, risk factors, junk food, obesity, all are associated. So the only response which is not associated is multiple myeloma, has nothing to do with obesity. Okay. Which of the following is not an aneuploidy? Again, a very straightforward question. Normal is euploid. Aneuploidy means extra odd number should be there. So what is Klinefelter syndrome? 47XXY. So obviously, it's Y. Okay, so obviously aneuploidy, trisomy 13. What is the other name for trisomy 13? Also called Patau syndrome. What is 21 trisomy? It is Down syndrome. So all these three are aneuploidy. So the right response here is Bloom syndrome. Bloom syndrome is basically an autosomal recessive disorder. The person will have an immunodeficiency. So that is Bloom syndrome. So the right response here is Bloom syndrome. A patient presents with multiple punched out lytic lesions in the skull. We are very familiar whenever we use this terminology, two differential diagnoses will come to us. One is multiple myeloma, other is Langerhans cell histiocytosis. But the question is more specific here. Which of the following thyroid malignancies is most likely associated with this particular radiological finding? And the choices are given all four thyroid cancers: papillary carcinoma thyroid, lymphoma thyroid, follicular carcinoma, medullary carcinoma. So we know that follicular carcinoma, papillary carcinoma metastasis to the cervical lymph node, thyroid lymphoma directly, it is a B cell lymphoma, follicular carcinoma metastasis to skull. And what is the nature of metastasis here? In follicular carcinoma, it will be osteolytic metastasis will be there. So multiple punched out lytic lesions, probably the diagnosis here is follicular carcinoma. So a quick recap on bone metastasis, or familiar slide which we have discussed so many times. Whenever we deal with blastic bone forming metastasis, remember prostatic carcinoma, small cell carcinoma lung. Lytic, remember multiple myeloma, RCC. Thyroid cancer, we will remember follicular carcinoma, thyroid. When we have mixed osteoblastic and osteoclastic, remember breast cancers, GI cancers. Next question. 26 years old man presents with a 8 months history of chronic diarrhea. Okay, a young person with chronic diarrhea. So barium enema reveals a classic finding, which is a rigid lead pipe colon with loss of haustral markings. So this classic line, loss of haustral with the lead pipe rigidity, which is the classic feature of ulcerative colitis. You know, in IBD, there are two types, Crohn's and ulcerative colitis. Crohn's will have skip lesions, ulcerative colitis will be continuous, and Crohn's disease can affect anywhere in the GIT from the oral mucosa till the anal mucosa, whereas ulcerative colitis will involve only the colon. The only involvement in ileum will be some inflammation from the colon can enter into the ileum like a backwash ileitis. And because of the chronic irritation, what happens? The normal haustray of the bowel will be lost. So these are the haustray, isn't it? So the normal haustrations will be lost. So the person will have a lead pipe colon in radiography. So as discussed, ulcerative colitis will involve the large bowel, whereas Crohn's any part. Ulcerative colitis will definitely involve the rectum. Crohn's can involve or need not involve. Ulcerative colitis will involve only the mucosa. Crohn's will have through and through involve the entire mucosa, submucosa, muscular layer and the serosa. The classic finding in Crohn's is granulomas, to be specific, non-caseating granulomas, whereas in ulcerative colitis, no granuloma. And lower abdominal cramps will be there. Here they'll have a tenderness, always bleeding, mucosal thickness. Here bleeding is very rare. Okay, and see this typical appearance. So this is the classic lead pipe rigidity. The haustray will be lost, and see this picture. So this is a very classic finding seen in ulcerative colitis. So the next question, we have a 55 years old woman presented with the bilateral, okay, multilobulated ovarian cyst with solid components. So whenever we have a combination of cyst plus solid components, we are dealing with carcinoma. Not benign or borderline, we are dealing with the malignancy. Imaging revealed the presence of ascites, so it means stage 4 with omental deposits, elevated CA 125. So all these clues point to a surface epithelial tumor. So here we have granulosa cell tumor, which is actually a sex cord stromal tumor. Mucinous and serous are the two options. Mucinous adenoma is benign, so we have the right response here is serous carcinoma. Remember, serous tumors are always bilateral, multilobulated, and this most commonly metastasis to omentum. So here the right response is serous carcinoma. Endometrioma has nothing to do here. Which of the following feature is not associated with granulosa cell tumor? Again, the question here is non-specific. If we have the right question, we will be able to answer it better. So here, granulosa cell tumor, GCT, granulosa cell tumor. So it is basically a sex-cord stromal tumor, which will have the classic Call-Exner bodies. See, for granulosa cell tumor, remember two C's. One is the Call-Exner body. Second is the coffee bean nucleus. I will show you. And what is the marker, tumor marker, which is actually inhibin. So Call-Exner bodies, inhibin, sex-cord stromal tumor. CA125, as we have seen in the previous slide, CA125 is a feature of surface epithelial tumors. Most commonly, serous cancers, mucinous cancers will have CA125 elevation. So here the right response would be CA125 elevation. I'll show you the picture. This is the classical picture of granulosa cell tumor. So can you appreciate that grooving here? Nuclear grooving. And as you can see here, the nucleus is palisading with the central pink material. So this is the classic Call-Exner body, which is the feature of granulosa cell tumor, and the marker is inhibin. Okay. So the last question, which of the following statements are true regarding H. pylori induced ulcers, probably gastric ulcers? Again, a very logical question, very simple. All individuals infected with H. pylori will eventually develop ulcer. Obviously, no, need not be. Ulcer development depends on the interaction between the host factors and bacterial virulence. Absolutely, yes. H. pylori is the only pathogen associated with antibiotic resistance. Obviously, no. Common sense will rule out. Usually, self-limiting, needs no treatment, need not be. Most of the people will be asymptomatic. Some can have symptoms, some can have gastric ulcers, some can have even cancers. Gastric adenocarcinoma, even a B-cell lymphoma is possible. So it needs a treatment depending on the clinical features. So the right response here is ulcer development depends on the interaction between the host and bacterial virulence factors. So with that, we'll be completing the discussion. Thank you.